We're pleased today to have Dr. Siti Hamzah, who is a consultant specialist in special care dentistry in Malaysia, working in the Department of Special Care Dentistry in Kajong Hospital in Malaysia. Siti, welcome, and we look forward to hearing your lecture. Siti will be talking to us on an introduction to oral health care for people with special care. And on the panel, we have Professor Callum Durward from Cambodia and Dr. Jacob Johns from University of Malaysia. Siti, we look forward to your lecture. Thank you.
Hi, everyone. It's a great opportunity to be here talking to you all. In this series of lectures, I'll be talking about the introductions to oral health care for people with special needs. I would like to take this opportunity to thank Global Child Dental Fund for giving me this chance to talk about the topic that is very close to my heart. A little bit of myself before I proceed with this lecture. I'm currently practicing special care dentistry in the Ministry of Health in Malaysia. So in Malaysia, special care dentistry service is actually based on the hospital settings. So we see outpatients, inpatients, as well as patients require domiciliary oral healthcare services where we actually visit the patients at home or institutions. And we also provide support to at the community level by giving consultations and advice not to just to the patients and the carer, as well as to the oral health general dental practitioners who require advice in managing people with special needs. So the main objective of these lectures is to give you an insight about special care dentistry and for you to be able to manage these patients, this kind of patients, after you have graduated from the dental school. Okay, in these lectures, I will be talking about the background of special care dentistry, and then the second topic to be discussed is the focus and scope of practice. It will then be followed by the oral health issues in special care dentistry, which I will be discussing about the barriers faced by the people with disabilities to get access to oral health care facilities. Then I will touch a little bit about the consent, about taking consent when you want to perform dental treatment for people with disabilities, as well as the legal perspective from each country. Okay, upon completion of this lecture, I would expect all the students to understand the concept of disabilities and be able to define special care dentistry. And also, I hope that you'll be able to identify the focus group in special care dentistry service and appreciate the types of service provided by specialists in special care dentistry. And I also hope that you can understand about the type of treatment that you may be able to perform as a general dental as the general dental practitioners. Other than that, please also check for yourself after this lecture whether you would be able to recognize the barriers to access for patients with special needs and recognize the common oral health problems in patients with special needs and identify the legal aspects involved in managing people with special needs, right? So also, I hope that you will be able to understand the process of taking consent involving people with special needs, because the process of taking consent for this group of patients is not as straightforward as you always do for other populations. Okay, there are things that you need to refer to. There are things that you need to check before you are able to gain consent from them or from the carer. So you must also be aware of the current local acts and regulation on people with disabilities, because each country have different acts and regulations with regard to people with disabilities. And you must also know about your limitations, and you must also know when you can treat these patients by yourself and when you can refer the patients to specialist care. Okay, the first topic is about the background of special care dentistry. So the subjects involved in this topic is first, I will be talking about the statistic about the prevalence of people with disabilities in globally, as well as in Southeast Asia region. I'll not be talking about it in details, but I think I'll just give you a general information about the prevalence of people with disabilities. And then I'll be talking about the special care dentistry definitions and the categories of disabilities in special care dentistry. The WHO, or World Health Organization, estimates that about 15% of the world's population experience some form of disabilities. This is equivalent to about 1 billion people globally have some form of disabilities. So using these estimations, they could be about 90 million of people with disabilities in Southeast Asia region. So having said that, you can estimate about 1 of 7 people in the world may experience at least one form of disabilities, right? So if you don't know what the countries in Southeast Asia region, I've just listed it out on the right side of this slide, which is Cambodia, Laos, Myanmar, Malaysia, Indonesia, Singapore, Brunei, Philippines, Thailand, Vietnam, and Timor-Leste. Okay, looking at the prevalence of the disability in each of the Southeast Asia countries, it seems that Indonesia has the highest prevalence of people with disabilities, and followed by Vietnam. And Brunei seems to have the least prevalence of people with disabilities, probably because of the small number of populations that the country might have. Okay, let's have a look at the definitions of special care dentistry. So the definitions of SCD, or special care dentistry, may be different from one country to another. So because the definitions may be influenced by the vision and missions of the healthcare service of each country, and probably be influenced by the nature of the healthcare services delivery in that particular country as well. So however, in Malaysia, we define special care dentistry as the oral health management of patients adversely affected orally by intellectual or physical disability and medical or psychiatric issues, or more often a combination of a number of these factors where such conditions necessitate a modified delivery of oral health care for patients' total health well-being. What it means that we deliver oral health care for patients with intellectual or physical disability, medical or psychiatric issues, and most of the time it is combinations of all these type of disabilities. And we include in our service the frail and dependent elderly as well, who are eligible to receive a special care dentistry service. Okay, in certain countries such as Australia and New Zealand, special care dentistry is also known as special needs dentistry. So in Malaysia also, for the past 10 years, we also use the term special needs dentistry to describe the service. But it just recently, in the year 2021, the beginning of the year, that we changed the term from special needs dentistry to special care dentistry. So in certain countries, they probably include the marginalized group populations and those with social or financial constraint to be part of the target populations who can receive special care dentistry service. But in Malaysia, we try to tailor the definitions more to healthcare issues rather than social and financial issues. Okay. Since, as I mentioned earlier, since special care dentistry is related to the healthcare services, so we categorize the patients as well based on the health concern. The first one is the intellectual disabilities, and then those with complex medical problems are also fall under the target populations in special care dentistry service, and those with physical disabilities, those with psychiatric and psychological issues, and those who suffer from multiple disabilities. Okay, let's have a look at the first one, which is the intellectual disabilities. All right, and so I think in the past, people used to describe intellectual disability as mental retardations, or calling the affected person as mentally retarded. Yeah, but nowadays I think that term mental retardations or mentally retarded is not really encouraged to be used to explain these situations. Intellectual disability sounds more polite and more respectful to these people. So this term actually explains those individuals who are unable, for example, to speak normally, or they can't communicate. They probably have limitations in understanding communications. Some of them are non-verbal, right? So, and they are unable to perform activities of daily living as other people. So they may need support in order to do so. So probably the more familiar examples that you can see in people with intellectual disability is Down syndrome, autism. I hope you have actually seen these kind of patients while you are studying. And those with global developmental delay. Of course, there are other examples, but I'm just giving you the most common examples that you may encounter currently in your student life. Okay, as compared to intellectual disability, physical disability is a type of disability that can be easily seen and can be easily identified, right? So for example, patients who are paralyzed, or patients who has a hemiplegia, paraplegia, tetraplegia, or patients who have cerebral palsy. I think those patients sometimes, you know, who are on wheelchair, for example, you straight away know that the patients may have some kind of problems, okay? But for the physical disability, it may be permanent, or it may be temporary as a result of accident, for example, right? So it's usually quite a few types of physical disability is not permanent. It means that it can be resolved later on, okay? Okay, this is just a little bit about the activities of daily living. In case if you have not heard about it, it explains about the ability of someone to perform basic physical needs independently, including personal hygiene. Personal hygiene may include toothbrushing as well, or grooming, dressing, toileting, transferring, or ambulating, and eating. Okay, the next one is the complex medical problems. Complex medical problems may or may not be directly related to disabilities, but then it can lead to disabilities due to medical issues that the patients may have. So it's actually interfere with their ability to perform activities of daily living, and due to the medical issues that they may have, the health professionals or the oral health care professionals may need to modify their treatment plan to suit their medical issues, or to make sure that the dental care is delivered safely and doesn't affect their medical illnesses, right? So for example, those patients with warfarin, then you have to check the INR first before you do dental extractions for the patient. Same goes with the patients with hemophilia, where you may need to communicate with the hematologist to check their bleeding status and all that. And then those patients with Alzheimer's, for example, if you're familiar with it, they have cognitive issues, and then how do you actually communicate with them and handle their behavioral issues while receiving dental care at the dental clinic. All right, psychiatry and psychology issue is quite common in the community. In Malaysia, for example, psychiatrists always refer their patients to special care dentistry service. So because these patients probably require a normal routine dental care, okay, they face the same problems as any other people in the populations, but then how we treat them is different. They may require a lot of behavioral modifications or behavioral guidance. They need a lot of support, right? Because of the emotional disturbance, things like that. And then for these patients, usually I would rather give treatment while they are in ward or as inpatients, because once we discharge the patients, it's very difficult for them to come back because they experience a lot of lack in social support. Sometimes they've been abandoned by the family members, so they feel some difficulty in accessing dental care facilities. So a lot of these patients as well are on psychotic agents. So as you know that some of the psychotic agents can cause xerostomia and dry mouth. So you have to know how to actually manage the xerostomia itself for these patients. Now, a lot of the time, our patients won't come to the clinic with single disabilities. Okay, they experience a lot of other type of disabilities, the combinations of the disabilities. For example, patient with stroke may come with us with physical disabilities as well as with cognitive impairment and other issues as well. Okay, so these patients can be categorized as having multiple disabilities. Okay, the second topic that I will be talking about is the focus and scope of practice. All right. So the subjects involved in this topic is the focus group, other than the categories of disabilities that I have mentioned to you earlier. And then I'll talk about the type of dental treatment that you can deliver for people with special needs in your practice. Okay, the first group is frail and dependent elderly patients. So in our clinic, in special care dentistry clinic, about 30% of the patients are geriatric patients who are frail and dependent. Okay, so we don't see patients and we don't accept referrals for elderly or geriatric patients who are independent, who can access dental care by themselves, but more towards patients who have a lot of medical issues and they need others to take care of themselves. For example, the most common examples among elderly is the stroke patients or patients with Alzheimer's or Parkinson's disease. So they need some modifications in the dental treatment delivered to them. The second group is I think I've talked about it earlier, patients with special needs from various categories. And those patients who are uncooperative, or patients with severe dental anxieties, patients with autism, and patients with a lot of behavioral issues may also be referred to us. And we can, if they are unable to receive treatment on the dental chair, then we will arrange for conscious sedations or general anesthesia. Yes, we do conscious sedations at the dental setting in Malaysia, especially inhalation sedations, and we do IV sedations as well, which is just currently acceptable in the Ministry of Health. All right, and then general anesthesia is easily accessible as well because we have a very good support from our anesthetist teams. Yeah. And the fourth group is, if you talk about special care dentistry, most of the time actually we focus on the adults who are 18 years old and above, but this may vary from country to country. Okay, when we talk in Malaysia, if we talk about special care dentistry, yes, we are talking about 16 years old and above. Below than that, they will be managed by the pediatric dental team. Okay, but it may be different in Indonesia. It may be different in for example, in Vietnam or in Cambodia. All right, so the special care dentistry may cover the whole group from child to adulthood. Okay, we actually do various type of dental treatment, routine dental treatment for these people, right? For this group of the populations that we're talking about. And we also do multidisciplinary oral healthcare management of patients with psychiatric and psychological issues. But bear in mind, it's not just these patients that we do multidisciplinary approach. For other patients as well with medical problems, and especially geriatric patients, we usually do it together with our geriatricians. We discuss about the treatment plan and also with physiotherapies and occupational therapies so that we can approach these patients holistically. Okay, looking at the specific type of treatment, actually we do most of the stuff that we do every day as a dentist. We do restorations, root canal treatment, preventive care. It's just that, let's say for example, for normal patients, you can actually do scaling within 30 hours, full mouth scaling for this patient, not 30 hours, within 30 minutes. You complete everything, but for our patients, you may not be able to do so. You may need to spend your time you know, I mean, spend about 15 minutes or 30 minutes just to do one quadrant. So, and then you have to proceed to the next step during the next visit. So these are the things that you need to see when you are formulating a treatment plan for these patients. We need to consider their financial support, their transportation to the clinic, the right time in order for them to come to the clinic, and then you need to see how long they can actually cope with the dental treatment on the chair, things like that. And another thing, if you want to do extractions for certain patients, there are things that you need to consider, whether the extraction is simple, if it is simple, how long it's going to take, and then how you will provide the treatment for them, whether the patients require antibiotic prophylaxis, or whether that simple extractions can be done just at the waiting area because the patients refuse to go into inside the dental clinic, inside the surgery. And if you have to do MOS or minor oral surgery, whether you need to do it, you can do it on the dental chair, you need to arrange another appointment, long appointment for the patients under sedations or under even under general anesthesia. These are the things that you need to look into. It's not just about the patients, but the whole thing about them, about the support, about the caregivers, about the medical issues, and whether you need to speak to other medical colleagues about their treatment, things like that. All right, apart from the dental treatment, the routine dental treatment, we also have a responsibility to monitor how the patients, how the oral health care is performed at home by the carer if they need the carer support. So every time when they come to the clinic on their regular dental checkup, we need to check whether the parents or the carer have a difficulties in performing oral hygiene care at home. And we also provide clinical support at the local community health centers, where we go and visit these centers or institutions, and then we give consultations, and we also do combined clinics with other medical and dental disciplines, for example, the psychiatric and also geriatricians. And at the same time, whenever it's required, then we will go and visit the patients at the institutions or at their homes to provide domiciliary oral health care services. Behavioral modification strategies is something that is very, very important that all the special care dentists need to know. Yeah, because a lot of our patients have behavioral issues that require a different approach. It will require effective communications, and you need to be a good listener to these patients and carer as well. Okay, the third topic is about oral health issues in special care dentistries. So as I mentioned to you earlier, that you need to be able to identify the barriers or challenges or the limitations that the patients may experience in accessing oral health care. Then only you can give support to them how they can overcome these problems and be able to attend routine dental care at the dental clinic, or you probably have to arrange a domiciliary care service for these patients. And being able to identify common oral health problems is also very, very important for you as a dentist. Okay, the first factors is unmet treatment needs. What it means is that our patients, our people with disabilities may have some difficulty in expressing the pain, or may have difficulties to tell you that the dental problems that they may have, and we also have problems to understand what they're trying to say, right? So most of the time, we are not sure whether, oh, okay, this is really the problems that the patient have. Okay, this is what we call as unmet treatment needs. And another thing is because of the high carer burden, for example, the carers looking after the people with disabilities have a lot of other things to do as well, and they probably not just care for one person, but they have to care for other people as well with the same conditions, or need to take care of other children as well, apart from the one with disabilities. And then they often forget about the oral care that need to be done for these patients. Okay. The other thing is about the increasing number of elderly populations. With the increased number of the elderly populations, we expect that they will experience a lot of medical conditions, a lot of medical problems, and which lead to some form of disabilities. So with disabilities, they start to have some limitations. They have mobility issues, and they can't actually access the dental care facilities, and which results in the negligence of the oral care. Okay. So the other things is a lack of sense of control in these patients. What it means that when they are in pain, they may not be able to cope with it, and they have behavioral issues. They become agitated, they become apprehensive, and then they cannot control their emotions. At the same time, if we are not as a dental professionals, if you are not trained in this, we probably lose our patients as well, and then we cannot cope seeing this kind of patients. Other than that, in the situations in a lot of the countries, like especially in the government dental clinic, the patients has experienced have difficulties to see the same dentist during the same visit, because the dental personnel keep changing from time to time, and then they cannot get to see the same dentist all the time. So it is difficult to build a sound rapport with the treating team between the dental care professionals as well as the patients and carer. And we also identified that some carer are not very supportive. They have they don't have a good attitude towards oral health. If they don't have that, then they also don't do it for the people that they are taking, they look after. Okay, this is probably nothing new to you. You may be familiar with this. Like gingivitis, periodontitis, caries. These are the common oral health problems faced by people with disabilities. The main reason because they are not able to perform oral hygiene care by themselves. They depends on others to do it for them. So what happens is, if as I mentioned before, if the carer has got poor attitude, even they don't clean themselves, don't do proper toothbrushing for themselves, how can they actually do it for these patients? So that is why a lot of our patients have this kind of problems, and then it will progress to a severe situations or severe stage, right? So it may look for normal people, I think if you look at this kind of situations, the first thing that you have to do is to do proper examinations and do scaling, full mouth scaling and cleaning. But at the same time, for people with medical problems, for example, you must tie all these problems with their medical issues, whether the patients have diabetes, for example, or is the patients on any kind of medications that probably causing gingival swelling, things like that. So everything must come together in order for you to be able to manage these patients. Okay, the last but not least is about consent and legal perspective. Okay, the subjects of this topic will involve the acts and regulation relevant to people with disabilities. Then I will talk about the process of taking consent for these patients, and just a little bit about the general procedures for referral before you decide to refer the patient to special care service. Okay, there are a lot of acts and regulations in each country pertaining to people with disabilities, but what I'm listing here today are the major one in each country. I won't be able to explain every single act in much details, but the main thing for me is for you to know what exists in your own countries. Like Magna Charta for Disabled Persons of 1992 is the main document to refer to in Philippines. So in Malaysia, this is the act. This is very important act pertaining to people with disabilities, which is called Person with Disability Act 2008 and Malaysia's Mental Act 2001. Right. So this is the one in Singapore, Mental Capacity Act 2008 and 5 years enabling master plan. Persons with Disabilities Empowerment Act 2007. This is from Thailand. And law number 4 of 1997 on the handicap, and law number 39 of 1999 on human rights. This is in Indonesia. And National Disability Laws on People with Disabilities 2010, and National Action Plan to Support People with Disability 2012. This is in Vietnam. I believe that you have that kind of law as well in other countries, in Cambodia, for example, but I'm sorry that I cannot trace it in the internet. So I tried to Google about the law on disability in Cambodia, but I cannot find it. So I'm sorry about it, but I'm sure you are aware of the local acts and regulations that exist in your own country. Okay, valid informed consent process. While you're taking consent for people with special needs, the first thing that you must make sure that you do an effective communications. So to do that, you must ensure that you use a proper language, use some language, or even if you use a sign language, make sure that it can be understood by the patients or the carer. Okay, if let's say the patient has severe intellectual disability and are able to understand or understand the communications, then it is important for you to make sure that the carer can understand what you're talking about. Okay, usually these effective communications need to be given to persons with sufficient capacity who can understand you, and give them some time to think about the decisions that you're going to do and think about all the information that you have given to them. So it is very important for them, in order to help them in making decisions, for you to give the treatment options and to ensure that they understand the procedures and potential risks, and to ensure that the decision is made voluntarily. Okay, it's not forced by anyone, or you don't force the patients to make that decisions based on your perspective. And you must be able, in order for the patients to do so, then you must be able to provide information on legal, professional, ethical, and other relevant standards. Okay, in determining capacity to consent, first of all, you must assume that or presume that all people who come to your dental clinic, if they are adults, they are able to consent unless proven not competent. So there are ways how you can actually assess whether the patient is competent to give consent or not. But as a general rule, those patients who are unconscious or a child under 18 years old, this is in Malaysia. So maybe in some countries they put the cut-off age point is 18 years old. 16 years old, but in Malaysia it's 18 years old. Those below 18 years old, they cannot consent for themselves. And a person after 18 and they are unable to understand the nature or the effect of the treatment also are not allowed to consent. This is according to the Mental Health Act 2001. Okay, there are factors that impact decision-making ability. The first one is the basic intellectual or emotional maturity, immaturity, severe intellectual disability, severe mental illness, and Alzheimer's disease. These conditions that are experienced by the patients may affect their decision-making ability. Okay, where a mentally disordered person is required to undergo surgery, they can also give consent for themselves if they are capable to do so. Otherwise, the guardian can consent for themselves or relative if the patient is unable or is incapable of giving consent. If in the absence of the guardians, the two psychiatrists, one of whom shall be the attending psychiatrist, can also consent for themselves, for the patients. Okay, in cases of emergency, we need to refer to the guardian if the patient is unconscious, for example, guardian to give consent. But if you cannot trace the guardian lives so far away, the patient is in other hospitals, right? So the two medical officers or two registered medical practitioners, as the case, maybe one of whom shall preferably be a psychiatrist. If there is no psychiatrist, then the two medical officers can also consent for themselves, for the patients. Sorry. So in determining whether or not a mentally disordered person is capable of consent, there are things that you need to look into, yeah, in order to make the decisions. So I think you can read it for yourself. But please consider, if you are the two medical specialists who need to make decision or to make consent for the patients, so you must make sure that it is in the best interest of the service user. All right. So it means that if you are in the patient's shoes, this is the treatment that you may have to undergo, that you want to undergo, things like that. Okay. Okay, looking at the procedure for referrals, okay, every attempt should, before you decide to refer the patient to the specialist, you should be able to at least make an attempt to provide treatment for these patients, unless if you find that the treatment required is not within your capability, you are not able to provide the treatment for the patients, or patient is very, very uncooperative and you are not skillful or trained to do it, then refer the patients to the specialist. Okay, however, it is advisable for you to contact the specialist first before you refer the patients, to make sure that it is appropriate for you to refer such cases to them. And also remind the patients to bring all the documents or the necessary documents before they go to see the specialist during the first appointment. Okay, as a conclusion, majority of people with special needs can be treated at the general dental practice. Okay, the problems may be sometimes access, or the oral healthcare professional is not trained or experienced in doing so. So just make sure that everyone with just to let you know that not everyone with disability requires special care. Dentistry is not all disabilities remain oral health. Yeah, some patients, they can still perform oral hygiene care by themselves appropriately. So these patients is actually not affected by their disabilities. Okay. Those persons who are able to express their needs and they are able to communicate about the problems that they have, they may not need the special care dentistry service. They can just get the treatment from the general dental practitioners. So when you're talking about special care dentistry, it usually relates to the patient's complexity rather than the complexity of the dentistry being provided. Okay, this is the last slide of my lecture. I hope I have been able to share with you some knowledge, and I hope it will be useful for your practice after you finish your study. Okay, and therefore I would like to thank all these persons listed in this slide, especially the Global Child Dental Fund, and also Oral Health Program, Ministry of Health Malaysia, and also all of my colleagues which have been involved in the preparations of these slides. With that, I thank you.
Siti, thank you for the lecture. That was excellent, and I think people will enjoy the colourful slides. They were really helpful, and they'll be very useful as an aid memoir. I'm going to open it up for questions and comments, and I'm going to turn to Callum first. Callum, is there any comments, questions that you would like to ask?
Yes, I was interested in one of your first slides, which was about the prevalence of disability in Southeast Asian countries, and the prevalence was so different between them. I wonder if you have any comments on why there seems to be this difference.
If you can see, if I'm not mistaken, if I can remember correctly, in Indonesia, the prevalence is very, very high as compared to Brunei. I think it's probably because of the number of the population in that particular country as well. And then the difference, as you can see, probably if I can refer to the situation in Malaysia, a lot of people with disabilities actually are not registered in their own country as people with disabilities. So perhaps in certain countries, such as the one with low prevalence, they may not have an access, or they may not have a knowledge that they can actually register themselves as people with disability in that particular country. So these are the things that I think government need to look into as well, so that we can get a very good data and reliable data as well from each of the countries. That's what I think. There is maybe there is a gap in terms of knowledge and awareness about registering themselves as people with disability, and about getting any prioritizations in the country. For example, in Malaysia, like people with disabilities can access, can get a lot of prioritizations when for transportations, for example, they may get an exemptions for the payment, things like that. So they should be aware of all this priority that can get in, so that it will encourage them to register in the registry of people with disability in each country. I think probably that's the reason why there is a huge gap among the countries in Southeast Asia region.
Thanks very much, Dr. Siti.
Are there any further questions, Callum, you had?
Yes, sometimes it's difficult for special care patients to attend the clinic. And do you think that tele-dentistry might have a place?
I think at the moment I think it's very, very true. Tele-dentistry is very, very helpful for some of them. I think it becomes much more obvious nowadays with the pandemic, with the COVID-19 pandemic nowadays. We thought that we actually have done that for our patients. Like we do the review for the patients online via certain apps like Zoom, or sometimes as simple as WhatsApp, as long as the patients or caregivers give consent to us. So it means, so I find that tele-dentistry is very, very helpful. We are currently doing not a project, like a pilot project to implement this tele-dentistry formally. But we have a few approach. Like my approach is like we communicate with the patients or caregivers directly, but my other approach we use, especially for those who live in the rural areas where they can access to the primary care dental setting, then we can actually do tele-dentistry with the dentist treating them within that primary care setting as well, where we can do consultations together with the health professionals, which I think is much more effective. And then we prescribe the treatment as well to them, and then see whether they can actually manage the patient at their center without needing for the patient to travel to us to get access. So that's another way for us to do tele-dentistry for special care patients.
It sounds very interesting and great opportunities in the future. Thank you.
Yeah, I hope so too. Yeah.
Jacob, any comments, questions?
Thank you, Dr. Siti, for the presentation, and nice to see a fellow Malaysian among the speakers. Dr. Siti, I would say that we in Malaysia, we are privileged that we have a system that supports the needs of people with disability, in the sense that we have specialists like you who have been there for a long time, and you have got your second and third tier groups of people supporting these persons with disability. Now, taking Southeast Asia for that matter, in a greater perspective, we may not be privileged in that sense. Many of our countries are still lacking in specialists as well as services as what is being provided in Malaysia. So what will be your take-home message for healthcare providers in these places that probably have not got this in their system yet?
Yeah, I think for the rest of other countries, especially in Southeast Asia region, without this specialty, the first things that we need to do is to get the support from the higher authority. I think once you get that support from the higher authority, everything will go smoothly. Because the thing is, in a lot of other countries, when you say that you want to do special care dentistry, it is more on individual effort rather than the efforts made by the government, for example, or the Ministry of Health. Like the situations may be different in our country, in Malaysia, because the initial intentions comes from the Ministry of Health itself. So it makes things a lot easier for us, because definitely they will support us, they sponsored us and all that. But for other countries whose the initiative initially comes from individual effort, I feel that they face a lot of difficulties. So what you can do is I'm not sure whether how easy it can be and how difficult it can be, is to get the support from the high authority or from the government, from the policymakers, in order to run it smoothly. So if you can get the funding, you can get the support from them, it will be much easier. So, but of course, different countries have different way of doing it, and they probably have different several limitations as well. And there are, of course, challenges in order to do so, because to convince, I think the most difficult thing is to convince the ministry or the government about how important it is to focus on the oral health for people with disabilities in their countries. And so we can give advice, but it's always different from one country to country. But we can become a good role model for other countries, looking at what we have done for Malaysia at the moment.
Good.
Thank you. So the role of bringing in all the stakeholders,
yeah,
on the board is very important. Thank you.
Thank you very much, Siti. It's really helpful, and I think it's a form of a really interesting debate. It seems to me that we can take several models. The number of people with disabilities and challenging for routine dental care is increasing. I mean, you mentioned the figure of 90 million and 15%, but that's going to rise because of a population that has a longer life expectancy. Do you think that we need to look at manpower very differently? Because I think the specialist model is very good, but I just wondered whether you think that we need to give some thought to situations like dental nurses with extended duties, etc., who might be able to go into care homes and go into different settings and be able to do more than they are legally able to do at the present time. Do you think we need to rethink our whole workforce strategy for?
Yeah, I think it's a very good approach to empower the dental nurses, for example, in order to perform like hygienist work. Like, because a lot of people with disabilities, they're having problems with their oral hygiene, maintaining their oral hygiene. So that's I think having the dental nurse or hygienist to be together with us and doing home visit or domiciliary service, I think it will be very, very helpful for these patients. So apart from focusing on the dentists or general dental practitioners or specialists, I think this group of health professionals in our fraternity can also be trained in maybe from a different approach in order to manage this oral hygiene care for this group of population.
I agree, actually. I think that's a complete rethink that we need to have. So maybe examination, as Callum has mentioned, with teledentistry, we might be able to do things, oral hygiene education, fluoride varnish, maybe extended not only to dental nurses, but also care home assistants and carers as well. It's radical for many countries to think that way, but I think that might be. But I want a specific question. Do you think silver dynamine fluoride has changed the way we care for people with special care needs, so that silver dynamine fluoride may well be used just to arrest the decay and give us time and manage people in domiciliary settings a lot easier?
Yeah, I think it's very good. We have started using it now for some of our patients, especially those with, who are uncooperative, unable to cope with a long treatment on the dental chair. Then I think arresting the caries is very, very important. And then that, because it's not a very complicated procedure to do as well. So we also implement that to do during our home visit or domiciliary service at, for the elderly patients at home or at the institutions or at the nursing care centers, things like that. And so we have started using it just about this year. So we would like to see more to be implemented, and then we can see the effect of what we have done for the patients. But I think it's a very, very good approach to tackle this group of people because it's fast and easy.
It is, and it's changing things. So we want to say thank you very much for the introduction today, because it's a really important area, and you covered it so well. So we're really grateful for your lecture. Any final comments or questions from Callum or Jacob?
No, I did enjoy the lecture and look forward to meeting you later. Thank you.
Okay, Siti, so thank you very much. We'll say goodbye now. And I think your work and the way you have structured it in Malaysia is a real example to us all. So thank you for highlighting the way you provide care. Thank you so much.
Yeah, thank you so much for the opportunity. Thanks.